We're now moving on to the poster Blitz session 2, where each speaker will have 3 minutes or less to present their poster, and you will see the posters here. And before each one, I will announce the title and the person presenting. So the first poster is the association between blood pressure variability with dementia and cognitive impairment, a systematic review and meta-analysis. And this is being presented by Philip Tully from Australia.
Excellent. Thank you for that introduction. This is an IMPRESS paper and it brings together a number of experts in the Variable Brain Consortium. Thank you. Next slide. So blood pressure, and especially hypertension in midlife, is a known risk factor for dementia. However, as Professor Ada Richard already spoke about earlier today, there is some uncertainty on the optimal blood pressure to maintain or preserve brain health. And we see that risk factors such as orthostatic hypertension are associated with dementia risk. So bearing in mind that dynamic nature of blood pressure, there's been renewed interest in blood pressure variability, which is measured between consecutive measures and as a consistent predictor of recurrent stroke. And we've shown last year in a meta-analysis it's also associated with small vessel disease. But the role in dementia is a tad less clear. And so what separates blood pressure variability from other risk factors that might vary is, well, blood pressure can be measured beat to beat, it can be measured ambulatory over 24 hours, but it can also be measured over longer periods. And so I think it should be clear that with such a variation in how to measure it, that there's actually no consensus on what the optimal way to quantify blood pressure variability is. And the mechanisms on screen are largely speculative, though they are suspected to be bidirectional. Next slide, please. Thank you. So we've done a systematic review with primary outcome of dementia, cognitive impairment, and a whole gamut of secondary outcomes that I can't cover today. The most important thing that I want you to take from the methods is that rather than introducing blood pressure variability as just another risk factor for dementia, we've actually compared it to effect sizes for mean pressure. So in our meta-analysis, 54 effect sizes, nearly 8 million people in a pooled sample, you can see the odds ratios on screen. And pretty consistently, blood pressure variability odds ratios were higher than mean pressure odds ratios, and they were all standardized. And so in our multi-level meta-analysis, we actually compared the effect sizes and showed that those for mean pressure were less strong than blood pressure variability effect sizes. So in other words, the relative contribution of blood pressure variability to dementia cognitive impairment risk exceeded that of mean pressure. Next slide, please. Thank you. So I present this with a number of limitations, and that really went in terms of secondary outcomes apart from Alzheimer's and cognitive impairment, particularly measured by the MMSE. The evidence was generally sparse and not consistent. There was also high heterogeneity and methodological and statistical. So in conclusion, the risk of blood pressure variability attributable to blood pressure variability for dementia cognitive impairment exceeded that of mean blood pressure. Thank you for your time. And if you're just a side note, we are doing an individual participant data meta-analysis. If you're interested in contributing data, please let me know. Thank you.
Thank you very much. Before we move on to the next poster, for those of you waiting in the wings, we are not having a presentation of poster 46 or 51. So just for those of you who are still waiting to present, that you know there will be no poster 46 and no poster 51. On to the next poster, the relationship of acute delirium with cognitive and psychiatric symptoms after stroke, a longitudinal study. And this is being presented by Vilde Nerdal from Norway.
Thank you. Hi, my name is Vilde Nerdal, and I'm presenting our study on the relationship of acute delirium with the cognitive and psychiatric symptoms after stroke. The study is longitudinal, and the patients were part of Nordkost, which is a Norwegian multi-center longitudinal study on stroke patients. Background and objective. Identifying risk factors for post-stroke disability is essential. Delirium is a common complication in the acute phase of stroke, and it's associated with longer hospitalization, higher mortality, and less independence by discharge. However, the long-term outcomes are less known. Therefore, this study aimed to examine how delirium in the acute phase of stroke impacts the cognitive and psychiatric symptoms over the course of 3 years. Our method: 157 stroke patients were screened for delirium with confusion assessment method, this during hospitalization. After 3, 18, and 36 months, global cognition was assessed by Montreal Cognitive Assessment Method, while psychiatric symptoms were assessed with the Hospital Anxiety and Depression Scale and Neuropsychiatric Inventory Questionnaire. In our analysis, we used mixed method linear regression with delirium, time, and their interaction as independent variables, MUCA, HUDS, and NPIQ as dependent variables, and adjusting for age, sex, education, baseline ESS, and premorbid dementia. Our results show that after 3, 18, and 36 months, delirium predicted higher NPIQ scores. After 18 and 36 months, delirium predicted more depressive symptoms, more anxiety symptoms, and poorer global cognition. Next slide, please. Our conclusion is that more research on the cognitive and psychiatric outcomes of delirium in stroke patients is needed. Long-term follow-up and treatment can be important in decreasing the burden of post-stroke disability. And I would like to thank my research group and my supervisors.
Thank you very much. The next presentation is neuropsychiatric symptoms accelerate cognitive impairment associated with small vessel disease. And this is being presented by Anna Aurola from Finland.
Hi, thank you for this opportunity. So we know from previous research that neuropsychiatric symptoms are associated with worse cognitive outcomes in overt cerebral small vessel disease, but less is known about how white matter hyperintensities are associated with neuropsychiatric symptoms and cognition in covert cerebral small vessel disease, where there's no presence of clinical dementia or stroke. So in our Helsinki small vessel disease study, we recruited 152 patients who were between the ages of 65 and 75 years old, and they underwent a comprehensive neuropsychological assessment, as well as a brain MRI, and filled in detailed questionnaires. The questionnaires in this study were the Neuropsychiatric Inventory Questionnaire, the NPIQ, which was filled in by 134 informants, as well as the Amsterdam Instrumental Activities of Daily Living Questionnaire, which was filled in by 132 informants. We looked at different cognitive domains, more specifically, global cognition, processing speed, executive functions, and memory. In our sample, the most common neuropsychiatric symptoms based on the NPIQ were depressive symptoms for 19% of the subjects, irritability for 16% of the subjects, and nighttime disruptive behaviors for 11% of the subjects. Next slide, please. We analyzed the data with linear regression models where NPIQ symptoms were either absent or present, and we found no main effects in terms of neuropsychiatric symptoms on cognition, but we found significant interactions. So the subjects who had high level of white matter hyperintensities, as well as the presence of neuropsychiatric symptoms, were worse off in all of the cognitive domains that we examined. We also found that functional outcomes were worse for those who had neuropsychiatric symptoms despite white matter hyperintensities. So in conclusion, it's important to evaluate neuropsychiatric symptoms in cerebral small vessel disease because it is related to worse cognitive and functional outcomes. Thank you so much.
Thank you very much. That was a nice presentation. Our next presentation is the brain renin-angiotensin system. Oh no, excuse me. The next one is systemic endothelial function and cerebral microbleeds, a cross-sectional analysis within the Rhineland study, which is being presented today by Gökhan Pehlevan.
Hi, everybody. Thank you for the introduction. Emerging data from animal studies suggest that endothelial dysfunction leads to cerebral microbleeds. However, data on this association in humans is scarce. Therefore, we aim to investigate to what extent systemic endothelial function is associated with cerebral microbleeds in a population-based study. Participants of the Rhineland study who underwent brain MR imaging were included this cross-sectional analysis. The Rhineland study is a population-based cohort located in Bonn, Germany, and recruiting participants aged 30 years old and above. Systemic endothelial function has been assessed as reactive skin hyperemia in our study with laser Doppler flowmetry on skin capillaries by using a local heating protocol. Heat causes vasodilation and increases blood flow in capillaries, and this vasodilative response reaches a plateau level approximately after 20 minutes of heating, and it is attributed to the nitric oxide production capacity in the endothelial cells. As illustrated in the middle, reactive skin hyperemia was calculated as the difference between baseline and plateau blood flow levels, and higher reactive skin hyperemia means better endothelial function. Brain imaging has been done with two identical Tesla scanners, and microbleeds were assessed as visually and categorized by numbers as no microbleeds, 1, 2, 3, 3 to 5, and more than 5 microbleeds. And then we investigated the association of reactive skin hyperemia to microbleeds using hurdle model. We computed two models. First one was adjusted for age and sex, and further we adjusted for cardiovascular risk factors and total brain volume. On the left-hand side, you see the population characteristics. We include a total number of 2,457 participants. Of those, 58% almost were women, and mean age was 54 years old. 306 participants had cerebral microbleeds in our cohort. 75% of them had only one microbleed, and the highest number of the microbleeds was 59. On the right-hand side, you see the results. Overall, reactive skin hyperemia did not differ between participants with and without cerebral microbleeds. However, among participants with microbleeds, better systemic endothelial function was associated with almost 30% lower odds of having microbleeds, and this was independent of age, sex, and cardiovascular risk factors. In conclusion, worse systemic endothelial function was associated with severity of microbleeds rather than with any presence. And this relation was independent of traditional vascular risk factors. And our findings support that systemic endothelial function is causally related to the development of cerebral microbleeds. Thank you.
Thank you very much. Our next presentation is the relationship between cognitive reserve and change in cognition during the first 3 months post-stroke. And this is being presented by Ragnhild Rådsnes.
Hi, thank you for the introduction. My name is Ragnhild Rådsnes, and I will be talking about cognitive reserve and cognitive impairment post-stroke. Cognitive reserve is a resilience concept defined as the brain's ability to adapt from damage and degeneration. It has been suggested as a protective factor for cognitive impairment in stroke research. We aimed to study the association between cognitive reserve and cognitive function at both 1 week and 3 months after the stroke. We also aimed to study the association between cognitive reserve and changes in cognitive function during the first 3 months. Next slide, please. 79 patients with mild to moderate ischemic stroke were assessed with a battery of neuropsychological tests within 1 week and then followed up at 3 months post-stroke. We used multiple linear regression to estimate the relationships of cognitive reserve proxies with cognition, controlling for age and sex. The cognitive reserve proxies were years of education, career, and a composite variable for IQ using the National Adult Reading Test and the Matrix Reasoning and Vocabulary Test from the VASI. Our measures of cognitions were composite variables for memory and executive function using the neuropsychological test listed on the PowerPoint. Next slide, please. Using a Bonferroni corrected significance level, we found that IQ was significantly and positively associated with memory and executive function at 1 week and at 3 months post-stroke. Occupation and education, however, were not significantly associated with either. Changes in memory and executive function were not significantly associated with either of the cognitive reserve proxies. Next slide. So, IQ was significantly positively associated with cognitive function post-stroke, which does support the theory that cognitive reserve protects from cognitive impairment after stroke. The lack of a significant association between cognitive reserve and changes in cognitive function may indicate that cognitive reserve doesn't promote a higher rate of cognitive improvement, at least not during the first 3 months post-stroke. We do need more research exploring how different factors such as stroke severity or time since stroke may affect the association between cognitive reserve and cognitive change. That is all from me. I will unfortunately not be available for questioning at the end of this because of another engagement, but I am available by mail, so feel free to contact me there. Many thanks to my academic supervisors, and thank you so much for listening.
Thank you. Our next presentation is Metabolic Syndrome is Associated with Poor Cognition, a population-based study of 70-year-olds without dementia. And this is being presented by Anna Marcelia from Karolinska.
Thank you, Deborah, for the introduction. And so the idea for this study came from the observation that while individual cardiometabolic conditions such as obesity and diabetes that also cluster together in the metabolic syndrome have been related to dementia, their combined impact on the preclinical stages of dementia remained unknown. Therefore, in this study, we aim to examine the association between metabolic syndrome and the domain-specific cognitive function, as well as the role of sociodemographic, cardiovascular, and genetic factors. The study population of these cross-section, the previous slide was fine, but okay. So the study population of this cross-sectional study included about 1,100 dementia-free septuagenarians from the Göteborg age 70 birth cohort 1944. Metabolic syndrome was defined according to the International Diabetes Federation criteria, therefore as the presence of central obesity plus at least 2 factors among reduced HDL cholesterol, elevated triglyceride, blood pressure, or blood glucose. Cognitive domains included 5 composite domains, such as memory, attention, perceptual speed, executive function, verbal fluency, and visual spatial abilities. And possible modifiers included education, categorized as primary school, secondary school, and higher education, heart disease, claudication as a proxy for peripheral atherosclerosis, and the presence of any epsilon 4 allele of the APOE gene. Next slide. Yes. Results show that metabolic syndrome was related to poor performance in attention perceptual speed, executive function, and verbal fluency. Interestingly, these associations were present only among individuals that were not carrying an epsilon 4 allele or that were highly educated. And among people with metabolic syndrome, higher education was related to a better cognitive performance. Next slide. Also, we observed that metabolic syndrome, together with comorbid heart disease or claudication, was associated with even worse cognitive performance than each condition alone. Therefore, we concluded that metabolic syndrome seems to be associated with cognitive deficit in the area of the fluid abilities, therefore poor attention and perceptual speed and executive function, and that education, APOE, and comorbid cardiovascular diseases may play a role in these associations. Thank you. I would like to, next slide. I would like to thank our collaborator at Karolinska and the Göteborg University, and also all these offices for their support. Thank you.
Thank you. Our next presentation is entitled Small and Large MRI Visible Perivascular Spaces in the Basal Ganglia of Parkinson's Disease Patients. And this is being presented by Stephanie Barbarian from Canada.
Hi, I don't think the slides are loaded yet.
Sorry, the cover page was not submitted.
Sorry? I can
Cover
share
page
my
was
own.
not submitted.
Oh, should have been.
Can you share your screen, Stephanie? Probably. Can she share her screen, Jeremy? Go ahead if you can.
It's not. Oh, I can't share when another participant is sharing.
You should be able to do it now.
Thank you, everyone. These are excellent presentations today. It's been a very good session so far. We've got a couple of minutes because of the two
Deborah?
posters that, yes,
Deborah,
Raj.
the cover page is not there, that's all. Otherwise, you can go on.
You want me to go on? Stephanie, do you want to look for your presentation? We'll come back to you.
I can share here. I think it's working now.
Yeah.
Are you
Good.
able to see?
Yeah, just remember to log off immediately when you're done so we can move on to the next presentation. All good.
Of course.
All right, thank you. Go ahead.
Okay. Okay, I'll just start with a brief introduction. So Parkinson's disease is a hypokinetic movement disorder where individuals have difficulty or an inability of initiating or sustaining movements. A well-versed tool used to assess disease severity is the Movement Disorder Unified Parkinson's Disease Rating Scale, or I'll refer to it by its acronym, the MDS-UPDRS. It has 4 parts that focus on different symptoms. Part 1 assesses daily non-motor symptoms such as cognitive impairment and mood. Part 2 assesses daily motor symptoms such as speech, chewing, and swallowing. Part 3 is assessing common motor symptoms you would expect from Parkinson's disease, like gait and postural instability. And part 4 assesses motor complications while taking into account dopamine dosing, which is a common medication taken by Parkinson's disease patients to manage their motor symptoms. This includes dyskinesias, which are those involuntary erratic movements that commonly occur in the face and limbs. We decided to focus on the perivascular spaces in the basal ganglia because this is a region of interest for Parkinson's disease, since this is where the dopaminergic degeneration occurs, leading to these symptoms. There's been evidence to suggest that there is a difference in pathogenesis and risk profile between small being less than or equal to 3 millimeters in diameter and large being greater than 3 millimeters in diameter perivascular spaces. Purpose of the study is to examine the small and large basal ganglia perivascular spaces and their association with disease severity in Parkinson's disease patients. Our patient population consisted of 139 individuals with Parkinson's disease recruited from the Ontario Degenerative Disease Research Initiative. Quantitative measurements on basal ganglia perivascular spaces, lacunes, periventricular, and deep white matter hyperintensities. And as I mentioned before, the MDS-UPDRS was used to assess motor and non-motor symptoms. Our main findings from the study was that small BG-PVSs were highly correlated with MDS-UPDRS parts 1 and 2, whereas the large ones were highly correlated with parts 3 and 4. This suggests that the BG-PVSs may differ in their impact in Parkinson's disease, where these small BG-PVSs may have an effect on PD-related daily motor and non-motor symptoms. However, these large ones may have an effect on motor signs and treatment-related motor complications. Further research may be is required focusing on these large BG-PVSs and if they're a more clinically relevant marker for PD neurodegenerative processes occurring in the striatum. Just want to thank you for listening to my talk today. I'd also like to thank the research team with a special thanks to Dr. Joel Ramirez and Dr. Sandra Black. And thank you for the funding agencies for helping support this research.
Thank you. And we will go ahead and move forward. Okay, Jeremy's got it here. The next presentation is microstructural changes in the penumbras of cerebral small vessel disease lesions are associated with cognition and sleep. And this is being presented by Joel Ramirez from Canada.
Thanks. Good job, Stephanie. Good morning, everyone. I'm just waking up, although the sunshine has not yet in Toronto, Canada. Next slide, please. So this was done again in Andre, which is a multi-site study in Canada. And we looked at 146 participants and patients with cerebrovascular disease. And we segmented some of these markers of small vessel disease at 3T MRI, so periventricular and deep hyperintensities, lacunes, and MRI visible perivascular spaces. And then we looked at diffusion metrics, namely FA and MD, in these penumbra layers surrounding each of these different lesion subtypes. And we actually looked at free water, but we just finished that analysis. So I'll share those with you later. Next slide, please. So you can see here in the figure, the different lesion segmentations, and then in different colors, you can see the penumbra layers surrounding each of these lesion subtypes. And what we did was we analyzed the, in the center of the lesion, and then as we go in the different layers surrounding each of these lesions. And we also looked at the gradients. So as you go from the center out, and what we did was we looked at associations with a large battery of neuropsychological tests. And those were categorized into different cognitive domains: processing speed, executive function, memory, visual spatial reasoning. But we also looked at sleep quality using the Pittsburgh Sleep Quality Index. And we controlled for basic demographics, vascular risk factors. And with the sleep analysis, we controlled for sleep medications and sleep apnea. Next slide, please. And so we have several different results depending on the different lesion type and different locations of the penumbra. So you can review those in my poster because there's a lot. But the main finding is pretty much what you find with a lot of these penumbra studies, which is that the damage is actually goes beyond what you see on standard structural MRI, and this could be assessed with diffusion MRI. And so it goes outside of all of these different lesion subtypes. Last slide. And I'd just like to thank my funders. The authors report no conflicts of interest, but we have a lot of funders because it was quite a large study across Ontario. That's all. Thank you.
Thank you very much. Our next presentation is serum placental growth factor as a marker of cerebrovascular disease burden in patients with Alzheimer's disease. And this is being presented by Liu Yun Wu from Singapore.
Thank you. Hi, my name is Lo, I'm a PhD student from the National University of Singapore. I'm here today to present our recent findings on serum placental growth factor as a marker of cerebrovascular disease burden in patients with Alzheimer's disease. Next slide, please. Next, please. Thank you. As we already know, there's a high, sorry, can you go back? Yeah, thanks. As we already know, there's a high prevalence of mixed cerebrovascular disease in AD pathologists and the pathogenesis of dementia. So in this context, identification of effective blood-based biomarkers would provide useful tools for diagnosis and treatments of mixed AD with CVD. So in this study, we're interested in a promising candidate biomarker, placental growth factor, PLGF, which is a member of the endothelial growth factor family and a potent pro-angiogenic factor involved in regulating endothelial signaling and vascular function. So previous literature has linked higher CSF PLGF to a higher albumin ratio, white matter hyperintensity burden, and presence of several microbleeds in patients with PDD. And CSF levels of PLGF are also found increased in AD and vascular dementia. But little is known about the alterations of peripheral PLGF in these disease conditions. So our aim is to examine serum PLGF in preclinical stages of dementia and in AD, as well as to investigate its associations with concomitant CVD and specific CVD and biomarkers. Next slide, please. So it's a cross-sectional study, and we measured serum PLGF in a total of 241 subjects recruited from a memory clinic cohort. We have non-cognitive impaired controls, NCI, cognitive impaired without dementia, CIND, as well as AD group. We found the serum PLGF was increased in AD as compared to the NCI controls. Next, please. Sorry, next, please. Thanks. And when stratified by both clinical diagnosis and absence or presence of CVD, PLGF was only, sorry, can you go back one slide? PLGF was only significantly increased in AD with concomitant CVD subgroup. And when looking into specific CVD markers, the PLGF was higher in subjects with confluent white matter intensity or several microbleeds. Next, please. In multivariate analysis, higher PLGF was associated with a higher burden of white matter hyperintensity and several microbleeds in AD after controlling for covariates including age, gender, and several vascular risk factors. And in conclusion, our findings suggest PLGF has potential utility as a biomarker for the presence of CVD in AD, and future longitudinal studies will be needed to determine its prognostic value as a marker for several vascular causes of cognitive impairment and dementia. Thank you so much for listening.
Thank you. Our next presentation is higher total cholesterol in ApoE4 carriers contributes to Alzheimer's disease risk. And these are findings from the Alzheimer's Disease Neuroimaging Initiative presented by Michelle Dunk.
Hi, thank you for your introduction. Next slide, please. So ApoE gene is the greatest genetic risk factor for Alzheimer's disease. And this gene also regulates blood cholesterol metabolism. So ApoE4 carriers who are at greatest risk for Alzheimer's disease also tend to have higher total cholesterol levels compared to non-carriers. So we wanted to investigate whether total cholesterol might be one mechanism underlying ApoE's conferral of Alzheimer's risk. And to do this, we examined total cholesterol differences between ApoE genotypes and between diagnostic groups. We also used Mendelian randomization to examine potential causality between total cholesterol and AD using ApoE as a genetic instrument. So our sample consisted of 1,534 participants from the Alzheimer's Disease Neuroimaging Initiative. And we performed a cross-sectional study. So we used baseline diagnosis of either cognitively normal, and that was the control group, or mild cognitive impairment or Alzheimer's disease. And we also used baseline levels of total cholesterol. Next slide, please. So we found that higher total cholesterol levels were observed in ApoE4 carriers compared to ApoE3 and 2 carriers. And you can see that in figure 1. And shown in figure 2, we also found that cholesterol levels, total cholesterol levels, were higher in all dementia groups. So those with MCI, those with Alzheimer's disease, and a composite dementia group, which included both MCI and AD participants. All 3 of these groups had higher total cholesterol compared to the control group. So based on these results, we hypothesized a mechanism that is shown in figure 3, where ApoE is predicted to indirectly confer Alzheimer's risk, in part through its influence on total cholesterol levels. And so we examined this using Mendelian randomization, and we found that higher total cholesterol levels were associated with higher dementia risk in ApoE4 compared to ApoE3 carriers. So figure 4 is showing these results in terms of log odds ratios. But in terms of odds ratios, which are more commonly used, we found that each increasing unit of total cholesterol was associated with odds ratios of 1.21 for Alzheimer's disease and 1.11 for MCI. And this was in ApoE4 carriers compared to ApoE3 carriers. Next slide, please. So overall, our findings suggest that dyslipidemia may be involved in ApoE's conferral of Alzheimer's risk. And more specifically, maintaining a healthy total cholesterol level may help reduce this risk, especially in ApoE4 carriers. Thank you for your time.
Thank you. Our next presentation is entitled, Does White Matter Hyperintensity Location Predict Cognitive Impairment in an Elderly Population? And this is being presented by Polly Rhodes.
Hi, thank you for that. Yeah, my name's Polly. I'm a medical student from the University of Manchester. So we're asking, does the location of white matter hyperintensities in the brain predict cognitive impairment? White matter hyperintensities, as we've discussed, are a common neuroimaging feature of cerebral small vessel disease. Increased total volume is associated with cognitive impairment and poorer cognition, but this association can be inconsistent. And therefore we ask whether the location might be more important. Next slide, please. And we specifically ask, is the location within specific white matter tracts more important? So we also used participants from the ADNI study, which the previous speaker, they used the same study group. So we took 399 elderly participants who had cognitive impairment. They mainly had mild cognitive impairment and a few had Alzheimer's disease. And we produced binary white matter hyperintensity lesion maps. So you can see on the right picture here, that's an example of a lesion map where each voxel has a value of 0 or 1, 1 being in hyperintensity, 0 being no hyperintensity. And you can see them in green on this map here. And we then put this into MNI standard space and layered it with an atlas of predefined white matter tracts, the ICBM DTI atlas. So you can see an example of that in the left image of the tracts. So then once we layered these images, we worked out the volume of white matter hyperintensities within each tract. And we put bilateral tracts together to increase power. And then we performed a multiple linear regression model where the percentage white matter hyperintensity occupancy within each tract was the independent variable. The dependent variable was MOCA score, which we chose because it's quite sensitive to early stages of cognitive impairment. And the covariates are listed on the page, on the slide. And if you go to the next slide, please. So this is just to show where, on average, where people in our study had white matter hyperintensities. So the map is an average of all their brain images, the lesion maps. and it's thresholded from purple being more than 2 people to red being more than 20 people. So you can see sort of frontal regions are commonly affected, and areas close to the lateral ventricles as well. Next slide, please. And then our results. So from the multiple linear regression, one tract significantly negatively impacted MOCA score, and this was the superior longitudinal fasciculus. And this was independent of covariates, including for total white matter hyperintensity volume. The beta coefficient is shown on the slide. And on the right, you can see in this image, it shows you roughly where this tract is in the brain. So it's a cortico-association fiber that runs from the frontal region to the parietal regions. And next slide, please. Next slide, please. Thank you. So this is an interesting finding because it supports the role of the superior longitudinal fasciculus as an important connection fiber within the brain, and it suggests that increased white matter hyperintensities here might impact cognitive impairment, perhaps more importantly than total white matter hyperintensity volume, because in this study, the total white matter hyperintensity volume did not predict cognitive impairment, whereas the volume within the superior longitudinal fasciculus did. And that's the end of my talk. Thank you.
Thank you. Our next presentation is entitled Prevalence and Correlates of White Matter Hyperintensities in Royal Canadian Air Force Pilots and Air Crew. And this is being presented again by Joel Ramirez from Canada.
Hello, me again. Next slide, please. So this is looking at white matter hyperintensities. This is a military study, actually, and this is based on some findings from the United States Air Force, U-2 pilots, where they found that these pilots, not only did they have higher burden of white matter hyperintensities relative to their age-matched controls, but they also found that some of these this burden was actually associated with lower cognitive performance. And these are otherwise healthy, high-functioning individuals. And so we decided to look at this as well, but in Royal Canadian Air Force pilots and air crew. Next slide, please. And so I was actually quite shocked to see these the MRI, or the flare MRI of these. These are quite young pilots, like 30s and 40s, high functioning. So I'm presenting some preliminary findings because we had to stop our study because of COVID. But we're starting it up again, and hopefully we can recruit everyone. Our target is 50, but we have 30 right now for analysis. So we're hoping to get everyone in before maybe lockdown might happen again. But of course, we have very comprehensive testing on these individuals because military personnel are quite compliant, but that makes it quite difficult to obtain this data. Next slide, please. And so here's some preliminary findings. I don't want to draw too many conclusions because it's just a subsample of what our target is. But we did find some encouraging correlations, and these are all controlled for Framingham risk, depression, metabolic syndromes, inflammation, and mild TBI. And we found some negative correlations with NBAC test performance, delayed matching to sample test performance, and the Shipley 2 vocabulary crystallized IQ. So hopefully we can have more results. And these are actually going to be combined with a larger NATO study. And hopefully that will also complete. Last slide. And I just want to thank all our funders for this study, and authors have nothing to disclose. Thank you.
Thank you very much. And our last presentation for this poster Blitz, and then please, if people have questions, put them in the chat. We will have a few minutes, but our last presentation, is gait and falls in cerebral amyloid angiopathy. And this is being presented by Brenny Sharma from Canada.
Thank you so much. We can move on to the next slide. Thank you. So for the current study, we were interested in a pathology called cerebral amyloid angiopathy, or CAA, which is a type of small vessel disease characterized by amyloid deposition in the small, medium-sized arteries of the outer regions of the brain. Now, gait is, although it may not seem like it, a very complex motor task that requires the coordinated efforts of several brain regions and networks. And while there's currently no shortage of studies looking at gait in various populations, there's actually very little known about the gait profile of individuals with CAA. As such, the objectives of our study were to determine if gait was impaired in CAA, and if it was, whether that impairment was associated with falls. Next slide. So for this study, we included, of course, individuals with CAA. We had healthy controls, as well as 2 other age-related diseases, Alzheimer's disease, AD, and mild cognitive impairment, or MCI. So all participants completed gait assessments on an electronic walkway, such as the one shown to the right, specifically performing single task walks and 3 dual task walks, such as walking while naming animals. We took data collected by the walkway system to develop 4 gait domain scores so as not to have too many redundant individual gait variables. These domains were pace, which included gait speed, as well as rhythm, postural control, and variability. Differences between these in these domains between groups were assessed. And additionally, participants completed questionnaires asking about number of falls, as well as their fear of falling. And we looked at the associations between gait and falls. Next slide. And presented here are the gait domain scores standardized to the normal control group for each walk. Very briefly, what we found was that CAA had significantly lower scores than normal controls on rhythm, pace, and variability. In addition to this, this impairment seen in CAA was similar to that seen in AD. Next slide. Regarding falls, we found that gait was not associated with the number of falls. However, at least in our study sample, both in the CAA group and in the full study sample, gait, in particular pace and variability, was associated with a fear of falling score. In the larger study sample, this association remained significant even after adjusting for age and sex. And last slide. So to summarize, gait was impaired in CAA, and better gait performance in select domains was associated with decreased fear of falling. So with all this being said, further research is needed to establish the underlying causes and or consequences of gait impairment in CAA. Thank you.
Thank you very much. Again, these were all wonderful, excellent presentations this morning. I think it's, yes, this morning. We've got a few questions in the chat. The first one is for Michelle Dunk. And the question is, should we screen populations for ApoE and give those with ApoE4 a primary prophylaxis with statins?
Yeah, thanks for your question. I think that might be one effective intervention to help lower Alzheimer's risk. But I know there have been some conflicting findings in terms of the effectiveness of statins with lowering that risk. Another interesting area of research is looking at the role of diet in relation to cholesterol and in turn Alzheimer's risk long-term. And a number of studies have found that if ApoE4 carriers minimize their consumption of saturated fat, cholesterol, and trans fat, that might be, in some instances, more effective than statin use. And interestingly, some studies, most of these are dating back to the 80s or 90s, but some studies show that E4 carriers, their blood cholesterol is actually much more responsive to these dietary changes compared to non-E4 carriers. So if statins aren't effective enough to get those cholesterol levels low enough, then if some patients are willing, then diet might be another way to go as well. But I think we definitely need more research in this area also.
Yes, thank you very much. The role of statins keeps coming up, I think, over the years. It's interesting. The next question that we have is for Joel, actually 2 more for Joel. You've probably seen those. But the questions are, were the white matter hyperintensities you see in the air crew more deep than periventricular? And was the distribution similar or different to what you might expect in SVD due to age? And then the other question also relates to age of the air crew that you measured these outcomes in.
Okay, so for age, we did control for age, although, we did see an age effect that was quite obvious, but we did control for age. The distribution similar, deeper periventricular. So there is both deep and periventricular. It feels like from the PIs of the study that the periventricular, they tend to look more like pencil thin. And so maybe not really sure. Although in some of the pilots, it's a little bit thicker. The ones that are thicker, they tend to have more deep. But is the distribution similar or different to what you might expect with age? It is different. And like I said, it's quite unexpected, although, a lot of my research experience is in dementia, so neurodegenerative disease. So those are elderly. And that's why I was quite shocked to see a lot of these hyperintensities in these younger, high functioning pilots. I do want to look at their ventricles, because if you notice, their ventricles tend to be a little bit larger than what I would expect with, I've only seen a couple 30-year-olds, so their ventricles tend to be little slits, whereas these look like to be a little bit larger. I wish we had the funding to look at it at multiple time points and see if these hyperintensities disappear or not. And then do we look at dose? So dose is a very interesting question in terms of number of years as a pilot, number of lengths. So we have multiple metrics for flight time. So there's just number of flights out. Well, we have hours of flights that they've logged in, but then there is high altitude. So U2 planes fly quite high. They're like surveillance jets, like Lockheed, I think, makes them. Whereas the fighter planes that these pilots, the Canadian Air Force pilots, are flying are not necessarily high altitude, but they are fighter jets. So they experience a lot of Gs. So we have multiple metrics for the different types of flight that they have, and we want to analyze that as well. I hope that answers everyone's question.
Yeah, thank you very much. And I had one question as well for the last speaker, and I may have missed it, but were the CAA patients, I'll call them patients, were they asymptomatic, or how did they look phenotypically?
Not asymptomatic, but definitely on the milder end. None were demented as per the study design.